The information shared on the Sky Women's Health podcast is for educational and informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding your medical condition. Never disregard professional medical advice or delay in seeking it because of something you heard on this podcast. Reliance on any information provided by Sky Women's Health, Dr. Carolyn Moyers, or any guests featured on the podcast is solely at your own risk.
You're listening to Sky Women's Health Podcast, your evidence-based resource for women's health and wellness, exploring the holistic principles of osteopathy, integrating mind, body, and spirit, designed to empower you as your own healthcare advocate and help you live your best life. I'm your host, board-certified OBGYN, Dr. Carolyn Moyers.
Hey, welcome back. I'm glad you're here today, because we're going to talk about something that every woman in perimenopause and menopause deserves to understand, and almost no one has explained to her. Honestly, I didn't learn about this in medical school, but this is something that's coming up consistently in the practice. We're talking about ferritin. I know, lab values. It sounds really dry, right? Bear with me, because by the end of this episode, I promise you're going to look at this little number on your blood work completely differently. Here's where this episode kind of comes from. At my practice, Sky Women's Health, we've been looking at the data because we're consistently seeing significantly elevated ferritin levels in otherwise healthy women. So when our pathologist ran the numbers on ferritin results, we across our patient panel and then compared us to other providers, we came in the top tier for elevated ferritin. And like I said, our patients on the whole are healthy women. So the question became, why? The answer, as it turns out, has everything to do with who our patients are. Perimenopause, menopausal, postmenopausal women in the middle of one of the most significant hormonal shifts of their lives, one of the many hormonal shifts of their life. We have puberty and pregnancy and postpartum, and then this menopause transition. When we started pulling the research, including a study published in 2025 in Scientific Reports that tracked iron biomarkers in nearly 2,000 women through that menopause transition, we realized that this is a story that needs to be told loudly and clearly in a way that actually makes sense. So let's get started. Okay, what is ferritin? Let's think about this. And why do we measure it? Most people, if they've heard of ferritin at all, it's been told it's a measure of iron stores. And that's partially true. Ferritin is a protein that stores iron in your cells and releases it when your body needs it. Your serum ferritin level in your blood, so that level you get back on your blood work, is used as a proxy for how much iron you have on board. But when we're getting this, we're getting it in a full iron panel so that you can see that iron, that total iron binding capacity, etc. Low ferritin, you might be iron deficient. That can cause fatigue and hair loss and brain fog and shortness of breath and poor concentration, things that, by the way, sound a lot like perimenopausal symptoms, which is one of the reasons this gets so tangled and confusing for many women. High ferritin, that standard teaching is too much iron, and too much iron can be a problem. It's associated with liver disease, cardiovascular risk, and a genetic condition called hereditary hemochromatosis. But here's the thing, ferritin is also what's called an acute phase reactant. So that means that your liver cranks it out in response to inflammation, infection, autoimmune disease, metabolic stress, liver dysfunction. All of these can raise your ferritin without your iron stores actually being elevated. And this is what I see consistently in my practice. Totally normal iron levels, but a wildly high ferritin. So when you got a ferritin result, you're actually looking at two things tangled together: your iron status and your inflammatory or metabolic status. And in certain populations, specifically postmenopausal women, those two signals can be very hard to separate. High ferritin doesn't always mean iron overload. It can mean inflammation, metabolic stress, or, as we're about to get into, a completely predictable physiology of menopause. So keep that in mind because everything we're about to talk about builds on it. Now let's talk about estrogen's role in iron metabolism. And I want to say up front that this is not something I learned in medical school. This is not in most general health education, but it should be because it changes how we think about iron in midlife women entirely. So, your body has a master regulator of iron absorption called hepcidin. Hepcidin is this hormone made in the liver, and its job is to control how much iron gets into your bloodstream. And when hepcidin is high, it blocks iron from being absorbed in your gut and from being released out of storage in your cells. And when hepcidin is low, iron flows more freely. Now, here's the key: estrogen suppresses hepcidin. So during the reproductive years, while estrogen is robust and hepcidin is kept relatively low, iron is absorbed readily and circulates freely. And premenopausal women lose iron every month through menstruation, right? So that monthly blood loss is a major regulator of your iron stores. It's one of the main reasons iron deficiency is so common in reproductive age women and why iron overload is so much rarer. Now, what happens during perimenopause? Well, estrogen starts to decline or fluctuate erratically. And as it declines, hepcidin rises and menstruation becomes irregular, eventually stopping altogether in menopause and your postmenopausal years. You've lost that monthly iron exit. You're not menstruating anymore. And your loss of estrogen puts a brake on hepcidin, and the result, iron accumulates and ferritin climbs. So in the 2025 scientific reports study that I mentioned earlier, they followed nearly 2,000 women through the menopause transition, real people tracked over years. Around the time of the final menstrual period, ferritin shot up dramatically. But then, unlike other iron markers like serum iron or transferrin saturation, which spiked and then plateaued, ferritin kept rising even months later, years later, still climbing. The researchers found that ferritin increased 3.46 fold compared to premenopausal levels. So 3.5 times in otherwise healthy women. And it wasn't leveling off. So why does ferritin keep going up when the other iron markers stabilize? Because ferritin is no longer just tracking iron. It's also tracking the body composition changes, the shift in fat distribution, the low-grade inflammation, and the metabolic stress that come with estrogen decline. And all of these drive ferritin. And that brings me to our 4 big reasons. So let me walk you through the 4 main reasons ferritin rises during the menopause transition, because understanding all 4 of these is what makes it a 4 complete picture. And why do I find this so often in my practice? Because I actually check an iron panel on all my patients at introduction and then annually. And I do this because I'm always looking at a complete picture. For instance, perimenopause, there's no lab value that identifies someone as being perimenopause. It is a clinical diagnosis, but we want to rule out other underlying causes. So I'm looking at your complete metabolic health before creating a customized plan specifically for you. And so that's why we see it more often, I think, at Sky Women's Health. Not only do we have this population of people going through a menopause transition, but we're also looking at the complete metabolic picture. Okay, so driver number 1, the cessation of menstrual blood loss. So we're stopping our periods altogether or slowing or decreasing. They're spacing out. This is probably the single biggest factor. So women in their reproductive years lose a meaningful amount of iron every month. And that loss actually is protective against iron accumulation. The moment periods stop, that exit route closes. Iron that used to leave the body every month now stays, and ferritin, the storage protein, reflects that accumulation. Driver number 2, the estrogen-hepcidin shift that we just talked about. Less estrogen means more hepcidin, which paradoxically means iron gets locked into tissue storage in places like the liver and spleen rather than circulating freely. So you can actually have high ferritin alongside a relatively lower serum iron or normal serum iron. So the iron is there, it's just stuck in storage. Driver number 3, body composition changes that we see in the menopause transition. The fat shifts from the hips and the thighs, where it's relatively quiet metabolically, to the abdomen, where it's not quiet at all. That visceral fat produces inflammatory signals. And since ferritin is an acute phase reactant that rises with inflammation, more visceral fat means higher ferritin, completely independent of iron stores. Driver number 4, insulin resistance. As estrogen declines, insulin sensitivity worsens, and insulin resistance is linked to elevated ferritin through multiple pathways: liver fat accumulation, systemic low-grade inflammation, disrupted iron metabolism. A 2025 study found that women with high ferritin levels that could not be explained by their transferrin saturation, essentially ferritin beyond what the iron picture accounted for, had significantly higher rates of fatty liver, elevated triglycerides, and worse glucose metabolism. In other words, the excess ferritin was flagging metabolic stress, not just the iron accumulation. So let me say that again, because I think it's one of the most important clinical takeaways from this episode. When ferritin is elevated in postmenopausal women beyond what iron status alone can explain, that is a potential window into her metabolic health. It's not just an iron number, it's a metabolic signal. So if we pair ferritin with transferrin saturation, if ferritin is high but transferrin saturation is normal or low, the elevation is likely metabolic and not iron overload. And that changes the workup entirely. So what does it mean in a practical sense? Okay, let's paint a picture here. Before I do that, though, it might be helpful to know what a normal ferritin level is. And it's going to be dependent on wherever you're getting your blood drawn, that particular lab, what they have for their normal ranges. For my lab, a normal range is anywhere from 13 to 150 nanograms per milliliter. Okay, so just so we kind of have a reference range for what we're talking about. I often see patients with ferritin levels of 190, 230, like significantly high levels in otherwise healthy patients. So here's an example. A 54-year-old woman comes in for her annual visit and has been postmenopausal for 3 years, feels tired, some brain fog, some hot flashes, hair is thinner than it used to be. Her labs come back and her ferritin is 185. The lab flags it as high, but what does this mean? The patient is disturbed and wondering, what do I do about this? Under the framework of this research, is asking us to use, a ferritin of 185 in a 3-year postmenopausal woman could reflect iron accumulation from loss of menstruation. It could also reflect inflammatory ferritin production from visceral fat redistribution. It could also reflect early fatty liver disease or insulin resistance, which is why we're also getting a CMP and a hemoglobin A1C, and we're looking at your liver enzymes. We're looking at your insulin resistance. Or it could reflect all 3 of these simultaneously, right? So it may not be one or the other. It may be yes and the ferritin alone doesn't tell the whole picture. So this is why it's so important that we take a comprehensive approach. So we have to look at, what is your transferrin saturation? What are your liver enzymes, fasting glucose, triglycerides, hemoglobin A1C? We're looking at the whole picture. Have you ever had a liver ultrasound? Do we need one? Do we have a family history of hemochromatosis? This is not about creating alarm over a ferritin number. It's about asking the ferritin to do its full job as a biomarker which means reading it in a context, not in isolation. And I want to flag something that the 2025 study authors said explicitly because I think it's important. Physicians should use caution when determining a patient's iron status based solely on ferritin levels. That's from the paper itself. Even the researchers are telling us don't use this number alone. One more thing worth knowing is the connection between elevated ferritin and fatty liver in postmenopausal women is significant. The studies found more than double the rate of fatty liver in women with high ferritin that couldn't be explained by iron status. And fatty liver, now called metabolic associated steatotic liver disease, is largely silent. Liver enzymes can be completely normal, even with fat accumulation in the liver, even when fat accumulation in the liver is substantial. So normal liver panel doesn't always give you a clean bill of liver health. If ferritin is persistently elevated and metabolically unexplained, it may be worth a conversation that goes beyond iron. So, elevated ferritin in a postmenopausal woman is a prompt to ask some questions, not just about iron, but also about metabolic health, liver health, and inflammation. The number is a signal, the context gives you the full story. Okay, I want to spend a few minutes on something that comes up constantly in the menopause space, and I want to address it honestly. Some very prominent clinicians recommend that women aim for ferritin levels in a range of 30 to 50 nanograms per milliliter as a target for symptom relief. The argument is that while the lab reference range might call 15 or 13 in my lab's case, a nanogram per milliliter normal, women can still experience significant symptoms like fatigue and hair loss and brain fog at those low normal levels. Is there science behind this? The honest answer is yes, partially, but the important caveats that I think there's important caveats that I think get lost. So there is research, mostly in premenopausal women, showing that women with a ferritin level below 30 can have significant symptoms, even without meeting the clinical threshold for iron deficiency anemia. There are studies showing that symptom improvement with iron repletion in that range in the context of younger women with heavy periods or someone with documented iron deficiency, that 30 to 50 target has a foundation. But, and this is significant, but those studies were done largely in premenopausal women where low estrogen generally reflects depleted iron stores. In postmenopausal women, the situation is physiologically reversed. Ferritin naturally rises. The body is accumulating iron, not losing it. And a ferritin of 35 in a 55-year-old postmenopausal woman means something completely different than a ferritin of 35 in a 32-year-old with heavy periods. So there are currently no randomized controlled trials showing that bringing that ferritin from 20 to 50 in a postmenopausal woman relieves her fatigue or restores her hair. And the symptoms really overlap between iron deficiency and estrogen deficiency. Those overlaps are enormous: fatigue, brain fog, hair thinning, poor sleep. All of those can be driven by estrogen decline. And without carefully distinguishing between the two, there's a real risk in attributing estrogen's depletion symptoms to iron and supplementing unnecessary. So more than that, a postmenopausal woman who is already physiologically accumulating iron, adding supplemental iron when it may not be needed could push that ferritin in a range that carries its own risk: liver stress, oxidative damage, worsened metabolic burden. The liver piece matters here. So iron overload at any level is a recognized driver of liver injury, and postmenopausal women are already at increased risk for fatty liver from the estrogen-driven metabolic changes we've been discussing. So my clinical take is to be cautious about blanket targets in postmenopausal women. The clinical picture matters more than hitting a number. If you're experiencing symptoms, work with your physician to understand whether your ferritin reflects iron deficiency, physiologic iron accumulation, or metabolic stress. Ideally, looking at all three aspects of them. Don't supplement based on a number alone, and make sure whoever is making the recommendation knows where you are in your menopausal transition, because the reference ranges we've been using were not built with postmenopausal physiology in mind. All right, so we've covered a lot of ground, and I want to bring it home with something actionable, because all this science is only useful if it helps us to have better conversations with our care team. So if you're a woman in perimenopause or menopause and ferritin has come up in your labs, either high or low, here are 5 questions worth asking. 1, can we run transferrin saturation alongside ferritin? These 2 markers together can give a more clear picture. 2, what's my metabolic context? If ferritin is elevated, ask whether it should prompt a closer look at liver enzymes or blood glucose, triglycerides, hemoglobin A1C, because that elevated ferritin is in postmenopausal women can be a window into metabolic health, and catching things early like fatty liver matters. Question 3, where am I in my perimenopausal status or in that perimenopause transition? This context changes that interpretation of every iron lab value. Perimenopause, newly postmenopausal, several years out, your physician should be factoring in your menopausal status before drawing any conclusions about that ferritin. Question 4, should we rule out hereditary hemochromatosis? If ferritin is significantly elevated, particularly over 300, genetic iron overload is worth ruling out. However, I see 200s and 300s in my practice as well, and these patients don't have hereditary hemochromatosis. It's a simple genetic test. This is something to discuss with a hematologist. And question number 5, do I actually need iron supplementation? If your ferritin is low, normal, and you have symptoms, have that detailed conversation. Make sure that your physician is thinking about your hormonal picture and not just defaulting to iron as the answer, because the symptoms you are experiencing may be due to estrogen deficiency. Okay, here's what I want you to take away from today. Ferritin is not just an iron number. In perimenopause and menopause, it's a hormone story. It's an inflammation story. It's a metabolic story. And the science is now catching up to what we've been observing clinically. And that's that ferritin rises dramatically through that menopause transition and keeps rising. And that rise is telling us something important about what's happening in your body well beyond iron stores. I don't want you to fear your labs, but just be curious. Ask better questions, get a full picture instead of reacting to a single number. If this episode sparked questions for you about your own labs, your own health, your own transition, I hope it helps you to walk into your next appointment with a little more confidence and a lot more context. So please share this with a woman in your life who is in the thick of this stage. This is the kind of information that changes conversations. We'll see you next episode. Until next week, be well. Thanks for listening. This episode is sponsored by Sky Women's Health. If you love this episode, follow the show so you never miss one. Share it with the women in your life and help more people discover it. Let's make it binge-worthy.